Hi everyone. Now that we've got Dr. Garcia on the line, I just wanted to go ahead and start on this real quick webinar, going over some of the growth hormone secretagogues and their use in practice. I'm Ryan Smith with TaylorMade Compounding. I'm going to be joined by, as I said earlier, Dr. Nicole Garcia, who's going over more of the clinical stuff and how to use these in your patients in your practice. Right now, I want to go over a lot of the science behind these products and sort of how to dose them. Compounding was started around 3 years ago in the United States, and we really brought a lot of these newer growth hormone secretagogues here and made them available. Things like the CJC 1295 with Ipamorelin, even the Hexarelin at one time, and we really specialize in peptide products such as these. And so with that, I'd like to get started and talk a little bit more about this pathway. This hormone pathway is one that's very, very important in a lot of our decisions. In particular, it really helps us show what the pathway, the hypothalamus pathway that we're mimicking, how we're mimicking the growth hormone releasing hormone and the ghrelin receptor, and how it can also be inhibited by the somatostatin and the things we need to do in order to get the maximum growth hormone effect, which will yield clinical results that Dr. Garcia will be talking about here shortly. First and foremost, these are always really good options as it relates to growth hormone therapy in a way that is not growth hormone. Here are some of the disadvantages of that. Obviously, cost with growth hormone being almost prohibitively expensive, the FDA not particularly liking it. The fact that exogenous growth hormone administration can also cause downregulation of your endogenous production. The fact that the IGF-1 to IGF-1 binding protein 3 profile is not as good with exogenous administration of growth hormone. We'll talk about it a little bit later. And then lastly, all the abuse and side effects are high, some irreversible, such as organ and heart enlargement. So as a result, the secretagogues give us a really, really good option on how to increase endogenous levels of growth hormone better. The pituitary has two receptors for stimulation, which we both want to take advantage of in our patients to get the maximal effect. And we'll go into why we use them both together at the same time. But the first one is the GHRH receptor, which is accepting benefit from the hypothalamus. And it traditionally would receive growth hormone releasing hormone. It's a 44 amino acid. We mimic that exogenously with three different products: the CJC 1295, the Tesamorelin, and the Samorelin. Those are all working on that growth hormone releasing hormone receptor and mimicking that hypothalamic input. The ghrelin receptor, or the growth hormone secretagogue receptor 1 alpha, is what accepts a lot of these other growth hormone secretagogues. Right here I've listed Ipamorelin, Hexarelin, GHRP2 and 6, as well as MK677. And so it's always important to find where these products are working, because they form our clinical decisions of what to use and how to dose it. So whenever we think about which secretagogues to start with, which are we going to choose from both of those sides, we know that the growth hormone releasing peptides are becoming much less available. About a year ago, the FDA asked most compounding pharmacies to stop producing GHRP2 and GHRP6. Hexarelin is sort of unavailable in the United States already, which leaves us just with MK677 and the Ipamorelin. And so clinically, we have two products for the growth hormone secretagogue receptor, and we have three products to choose from for the growth hormone release receptor. And so how to know which one to use and when and what situations, what we'll be going over. First and foremost, we always like to compare CJC and Samorelin. Samorelin has always been very, very popular, but recently the CJC has popular as a result of it having a much better binding. Based off the exact same amino acid sequence, 29 amino acid sequence change in the CJC to get much more, essentially much more effective and have a much longer binding time. And so right here, again, we go 30 minutes with the CJC versus 8 to 12 with the Samorelin. And so we know that another name for the CJC is called tetrasubstituted modified growth releasing factor, which is basically just saying that it's got 4 amino acids changed of that 29 amino acid sequence. And we still see that it's a better therapy because we still get pulsatile secretions, better clinical results, low side effects, and sustainability. And so usually the Samorelin might have a better cost, but the CJC is probably a little bit better as it relates to its clinical protocol. also want to go over some of the problems with the GHRPs. Traditionally, GHRP2 and 6 have been used with high frequency, and some of the first ones to be created. GHRP6 was actually created before they even knew that the endogenous ligand was actually ghrelin. However, they have some issues with hunger and increasing some other hormones, which are not great. Ipamorelin is the opposite of that, has very, very few side effects, and actually is described as the first growth hormone, selective growth hormone secretagogue, and it still has the best profile of secretagogues available. The other thing that I really want to make a big point of, and this is something that people oftentimes miss, and that is that the GHRH receptor exerts a permissive action over growth hormone secretagogue activity. This picture on the left shows what happens whenever we dose everything together versus independently. And what you can see from the very top line on that line graph is that whenever you the growth hormone secretagogue with the growth hormone releasing hormone, you get much, much better benefit, almost 5 to 10 times the area under the curve. If you have you might have a lot of patients who pay attention to bodybuilding sites and some key opinion leaders and influencers who might say that they should use Ipamorelin by itself, and this is not recommended. As you can see towards here, even just one single dose of a GHRP leads to a 2-hour complete blockade and can cause some heterologous desensitization. That's what we'll talk about a little bit more later. But essentially, the one thing you want to take away from this is to never dose a growth hormone secretagogue in and of itself, because it can cause more desensitization and become really a therapy which is not sustainable. The other thing we always talk about are dosing and what's the most effective dose to use. Here I've listed a study looking at the growth hormone releasing hormone, showing that the pituitary saturation dose for these things are around 100 micrograms, generally 1 microgram per kilogram. And so going over this doesn't seem to be hardly more effective. And then in the same study, you actually also see that there's not really a saturation dose as we see it for ghrelin or the GHRPs. However, we do see that the best bang for your buck happens around 100 to 200 micrograms in terms of results for dose. And beyond that, you should be really, really conservative with your growth hormone secretagogue doses as well because of that tachyphylaxis and reduced response if you overdose. The other thing I want to say is that if you see products which are available as sublinguals or nasal sprays, you should be highly skeptical. This study done on the Peptide, or the other name for Peptide, growth hormone releasing hormone 129, shows that you had to use 50 times the concentration of IV or subcutaneous dosing if you try to do it orally, sublingually, or nasally. And so obviously that's not very cost effective and not a great strategy if you decide not to do anything but an injectable form. Going a little bit more into the ghrelin receptor, because this is very, very important. That growth hormone secretagogue receptor, as I mentioned, is highly prone to downregulation. And so one of the things we want to do is not hit it too hard. This sort of goes into that. The growth hormone secretagogue receptor has actually 2 dimers. One is the growth hormone receptor 1A, and then the other one is 1B. And it's expressed differently all over the body, but has a high level of conservation across species. So we know it's really, really important. And what we see is that the growth hormone secretagogue 1B actually prevents the 1A receptor from doing its job. And so what can happen with high doses of things like GHRP6, Ipamorelin, or GHRP2 are that you cause a reduced response. So it might have a great response for 1 month or 2 months, and then you start to see results. And so as a result, we have to be very, very conservative on dose and make sure that you don't dose it too high. Otherwise, you will stop getting a response. And along with that, that's another reason you always want to dose it with something like Peptide, CJC, or even something like the Ipamorelin. Lastly, I just want to talk about some really, really cool developments which you will see in the field in the next 2 to 3 years. And that is that in addition to all of its effects with ghrelin, the growth hormone secretagogue receptor 1-alpha can actually also dimerize with melanocortin receptors, which are dopamine receptors, and can affect things like the ability to orgasm, as well as treating things like depression. And so you will see this in the coming years. In addition to its effect with dopamine, it also has effects with serotonin and a lot of other neurotransmitters. And so you're going to see some products that are designed for this as well. And this goes a little bit more into that melanocortin-4 receptor and exactly how it will complex and dimerize with the growth hormone secretagogue receptors. The last of the products I want to talk about is the MK677. I mentioned that it goes to the growth hormone secretagogue receptor, but this is an oral ghrelin mimic that's not a peptide. It's a small drug molecule, and generally in the 6-month courses, you actually see an increase in appetite and total body weight. You don't see an increase in fat mass, but you do see an increase in lean muscle mass. As a result, this is most often used with people who can't take injections or are sarcopenic or elderly or even anorexic. And the people who are looking for this in terms of body comp and still want to lose some weight will often pair it with something like phentermine or the tesofensine in order to reduce some of that appetite. And so the other option that is fairly common, and I know that Dr. Garcia will be speaking about, is the CJC with Ipamorelin. This can be done multiple times a day. As I mentioned, that pituitary saturation dose is 100 micrograms, so sometimes people like to do it multiple times. The side effects include flushing, some sleep disturbances or injection site redness. The most common dosing that we would do as a pharmacy for our physicians is 200 micrograms of CJC and Ipamorelin daily once before bed. And this absolutely, like most of these products, they should be dosed on an empty stomach because insulin will increase somatostatin, which will block the growth hormone response. And so as a result, definitely do it on an empty stomach. This just goes and shows you the clinical research on the flushing, which is around 30%. In our experience, it's probably a little bit more than that, but I also will let Dr. Garcia talk about that. The other thing I like to just point out with these things is that you actually increase your pituitary messenger RNA of these products, and as a result, even if you were to stop these, you would actually have better secretion of growth hormone than when you started. A lot of people often ask, hey, is this like testosterone where if I go off, I'm going to have a withdrawal period, or do I need to keep doing this? And the answer is even if you stop, you actually have better secretion than when you started. The other thing I just really wanted to quickly talk about was Ipamorelin. This is obviously one that Biologic can do as well, which has a particularly a positive category and a lot of objective factors. It improves body comp, increasing IGF-1 by 181 points on average, reduces carotid ventral media thickness, visceral adipose tissue, triglycerides, improves cognition. It's a very, very powerful product, but it's also expensive. Considered definitely the strongest and best hormone-releasing hormone available. The last, and this goes into sort of the results seen with the IGF-1 and its commercial Agrifta, and this is the reason there's only a 14 in dose from the 1 milligram to 2 milligrams. So in most of the integrated medicine anti-aging circles, it's still dosed at 1 milligram. One other really big thing I want to talk about that's often brought up is the history of cancer and the risk of proliferating that cancer with something that increases growth hormone. This is actually pulled directly off Ipamorelin or Agrifta monograph approved by the FDA, and it says if you have a history of active cancer, it's not. That's the only contraindication. It does not say anything about the risk of past cancers, which hopefully will give us a little bit of information in terms of prescribing guidelines. And again, this just goes into the dose, which is that you have usually 1 milligram daily, subcutaneous. It doesn't seem to have the same sleep benefit as the CJC Ipamorelin, but is also highly potent at inducing its effect. The other thing is because this is hitting a growth hormone-releasing hormone receptor, just like Ipamorelin or just like the CJC, it doesn't have any downregulation of itself. So you can dose this one consistently and for long courses without having to worry about tachyphylaxis. This sort of summarizes these, and I would be sending this PowerPoint out to everyone after the presentation. The last thing I want to talk about is still with that cancer and the IGF-1 and IGF-1 binding protein 3, whereas IGF-1 is highly correlated to certain types of cancers, such as prostate, colon, and breast. IGF-1 binding protein 3 is inversely correlated and is actually protective. And so the growth hormone secretagogues actually change that ratio a little bit more than exogenous growth hormone and might seem to be a little bit more protective. So definitely something to consider. The other thing with these products is that often happens that people will develop autoantibodies, but it doesn't seem to affect them clinically as IGF-1 and visceral adipose tissue and some of these things did not seem to change. And so you might see some injection site redness, you might see some IgE responses, but it generally won't. And so with that, I tried to go through it as quickly as possible to give Dr. Garcia the most time. And with that, I will more than happy to change it over to Dr. Garcia and have her talk a little bit more about her experiences.
Can you hear hear me okay?
Yeah.
Okay.
Wait.
And how do I don't see my slides. Are you pulling them up right now?
Yeah. Well, in fact, I might go ahead and continue to share, and you should be able to control.
Yeah, there we go. Forgive me, I'm not used to doing webinars, but I don't see, and I'll just probably have you advance it, Ryan.
Perfect.
You can. There you go. Okay. So I was asked to give this along with Ryan. I would say more to talk about how I present the programs to my patients, not so much get into the science, although I will discuss what benefits my patients do see to the different products. What I did is I pulled some slides from a presentation that I was supposed to do at last year's offsite, but I wasn't able to make the offsite, and where I was going to discuss programs in general. So that's why you're seeing this slide. We're not really discussing sexual wellness, RG3, or sarcotropin. So it's just really an example that my favorite program out of all of them are the GHRPs. And my favorites are the CJC Ipamorelin, and also I do use Somorelin and Ipamorelin combo. Okay, you can go to the. So when I was going to discuss the programs, because we have several choices, I look at the GHRPs as the low-hanging fruit because based on our patient population, the majority of patients we see are 45 and older. Just based on chronological age, we can really a lot of times assume that the growth hormone levels are really going to be suboptimal compared to where they were in these patients when they were in their 20s and 30s. And most patients I find mark yes to at least one of the questions. I do use the questionnaire, and I'll talk about that in a future slide. And the questionnaire has changed since the offsite a year ago. We used to have kind of growth hormone deficiency symptoms in orange, and now we kind of split them up and have them in orange and red. But I find that most patients are going to mark yes to at least one of those questions, which doesn't necessarily automatically diagnose that they have hormone deficiency, that it's just not optimized. And I would say I'm a little bit biased because therapy over the past 10 years, I have checked my own hormone levels on a pretty regular basis and find that, you know, my estrogen, progesterone, testosterone levels are, through whatever I need to do, pretty balanced. But yet starting in my mid to late 40s, I started to notice definitely changes in increased body fat, decreased ability to repair and have that strength and stamina with exercise. I seem to have more aches and pains from mild things, I would say, and definitely have seen a difference in skin elasticity. And again, assuming that my adrenals were pretty well balanced, my lifestyle, meaning, you know, my diet, exercise routine, really none of those other things had changed, and other things were not really out of balance. I really felt the changes coming from, I believe, hormone deficiency. Okay, next slide. Another slide was left in. I forwarded all the slides from my presentation. So Male Kit A is probably my second most popular program, but we're not really talking about that today, although it's a good example when I talk about how I'm going to present a program. But you can skip this and go to the next slide. That's what we're talking about tonight. So 3 years ago, our keynote speaker at our offsite is a physician. His name's Mark Tager. About a year and a half ago, he had a webinar that I attended that I thought was excellent. And the topic was how to present your products and services to your patients, because whether you're going to call it selling or promoting or presenting, these are things that we do in our practices when we have additional services. And this seems to trip up a lot of doctors. So that's why I made this really the topic, you know, the key part of my talk. So he summarized, I tried to take all the really key points from his talk and summarize them here that I thought were really valuable. And he says that the 5 things to never really do when selling or presenting a product or service is, I never really think of selling as a contest between me and my patient. I'm simply trying to hear what their symptoms are and try and pick the best product or service. I don't really focus too much on the GHRPs by describing them alone. So what he means by that are you're going to talk. And I think sometimes we feel like we have to be experts like Ryan is on how the GHRPs work. And that's definitely not something that I'm excellent at. I would defer that to Ryan if you have detailed questions of how a GHRP works. But it's rather kind of knowing the basics about it, but really focusing more on how the features of that GHRP are going to benefit your patients and connecting that for your patients. So then we also, Ryan described, the cost, and growth hormone is very expensive, but GHRPs aren't either. But that doesn't mean you shouldn't offer it to your patients. So you never really want to make decisions with your patient's wallet. You don't need to think that they can't afford it. You don't really know what the patient is willing to put their money towards. You never really can assume what the patient wants or needs. You need to ask them, and that's why the questionnaire is very important, and I'll talk about that in a later slide. And I thought this last point was really valuable. Look at my role as a doctor seeing patients in my practice. My job is to really facilitate a value exchange in which I help my patients get what they want. And that's really what it comes down to when we're talking about a program, especially GHRPs. So he broke down a presentation of how you're going to talk about a program into 3 different parts. The first part is the feature, and that's where you're going to talk about the GHRP. But I'm certainly not going to go into the details that Ryan does. Now, this is a little bit it's a little outdated because I'm not really doing this more with GHRP 2 and 6. I'm going to be talking more now about CJC with Ipamorelin or Samorelin with Ipamorelin combined. But I'll simply say something like I would recommend consider we have called CJC and Ipamorelin. These are a combination of 2 growth releasing hormone peptides that are going to help send a stronger signal so that your pituitary gland, where growth hormone is made, it's going to help release a higher amount of growth hormone than what you're currently doing. And that's where my discussion of what a GHRP, that's about how much time I spend on it, 10 seconds. I'm simply going to say it's going to help release a better amount of growth hormone in your body. And then he talks about something, going to use a bridge example. Patient wants to know, okay, that's the product. What's that going to do for me? And so a bridge example would be so that you can, or this will help you to, or this will help you in order to sleep better, or it will help you improve recovery at the gym, or this will help you with your weight loss program and body fat to muscle ratio. This will help improve your skin elasticity. So I think sometimes as doctors, we're first and foremost scientists and clinicians, and we're very clinical and analytical. And we sometimes think we need to teach the patient all about the mechanisms of the HRP. But at the end of the day, the patient simply wants to know that this product that you're describing to them and have knowledge of will help them get to where they need to be as far as whatever those symptoms are. Okay. So hopefully that makes sense. You can go on to the next slide. So to introduce the GHRPs, I always have patients fill out a questionnaire, and I think everybody knows what that is. And the patient will fill out the questionnaire at every visit, and I don't necessarily go through every symptom on there, but I look at areas that are high and where the patient marked yes. And that is a very easy way of introducing a GHRP product. Like, oh, I noticed here you're not getting the results you want at the gym. You've noticed decreased stamina. You've noticed more body fat. And I will also ask them how they're sleeping at each visit as well, even though it's not on the questionnaire. I don't really, again, try and teach them how to be an endocrinologist. I think that's important. Again, I think to know that you have basic knowledge of the product, but I don't need to get into the details of the GHRPs and describe the science behind all of it. but I also think a really important strategy that's worked really well for me is I've tried the different products myself. And I don't necessarily share my story with every patient, but I obviously believe in the product. That's the first step at feeling comfortable presenting it. So that's worked really well for me. I would say that when I've used just about any of the GHRPs, I notice a little bit of weight loss right away. And for me, sleep is not so much of an issue, but I would say it's helps improve my sleep a little bit. And it also really helps with that recovery and repair with exercise. I don't feel as achy. I don't seem like I'm as prone to injuries and feeling sore after my workouts. The other thing is I do is I keep the brochures on the different programs and the HRPs like Shape Pro, Performance Pro. I keep those brochures right on my desk, and then when I start talking about the questionnaire with the patient, then I reach for the brochure, open it up to the area that has those bullet points, what the benefits are going to be. So I'll open up the brochure and I'll say, so we're talking about the Ipamorelin will help you achieve these results. And I just put all those bullets. I think that makes it very easy for the patient to connect the product with, oh, it's going to help me get to where I need to be. Okay. You can go to the next slide. So Deb, another slide that, well, didn't create a slide, but to talk about what's the biggest feedback that I get from patients on the GHRPs. I would say the number one feedback I get is sleep. Unfortunately, despite helping patients with their hot flashes, night sweats, using progesterone orally or whatever I'm going to do, insomnia is an issue, and GHRPs aren't 100% effective in making sleep perfect in all my patients. I find that this is really the secret sauce. It seems to really help a lot. And I do emphasize to patients that they're not just going to use a GHRP and lose weight dramatically from it. I tell them, and what I found in my own self is that it helps me maintain my weight. And when patients do enter into a structured weight loss program, they see better results when on a GHRP. Skin elasticity, I will have patients. Some patients will say that they noticed the crepiness improve. I would say that that's something that's further down the line. They're really going to probably have to use a GHRP for at least 3 months. But as far as benefits and the timeline on this, I find that the sleep is the immediate feedback, usually within the first. I don't tend to see that takes a long time for patients to notice the difference. In my male patients who work out a lot, I see a huge change when, especially after I've optimized their testosterone levels. I know that their levels are just about as high as they can be, but they're still wanting to achieve better results at the gym and better body position. Adding a GHRP really helps. And Ryan, I was going to ask you, you were saying that these need to be taken on an empty stomach. I usually I tell them to, they can eat dinner, but just to wait at least 3-4 hours before injecting at bedtime. Is that okay?
Yeah, absolutely. We typically recommend just a minimum of 90 minutes after eating, and we to be sort of less complicated. As long as they don't do carbs or fats, it's generally okay. Proteins seem not to obviously cause that insulin spike, which will reduce the effect. So yeah, I think we're definitely on the same page there.
Okay, because some patients, think empty stomach, they think they have to be fasting, and I use these products at bedtime. So, okay, I figured I didn't know what the timeline was.
Definitely. Yeah, and just a question for you on that as well. In your experience with the Psamorelin versus Ipamorelin versus CJC, or even some of the GHRPs, have you found that any of them affect hunger clinically more than the others?
The only time I was seeing that was when we were using the GHRP 2 and 6. And I had the occasional patient back when because the first product I started with was injectable Psamorelin with the GHRP 2 and 6. And I had occasional patients say, gosh, I feel really hungry. And so I would then change to the Psamorelin with GHRP 2 and take out the 6. And that seemed to help. But I have not really, on the newer one, just Ipamorelin, or even like the Smorelin, Ipamorelin. I haven't seen that.
Gotcha. Thank you.
Yeah. No, that hasn't really been a problem. So,
So with that, I mean, it might be good. Maybe just we'll open it up for some. In case there's any, you can feel free to chat it in the chat, and we'd be happy to do it. And then in the meantime, if you don't mind, Dr. Garcia, I also just wanted to, I should bring up some of those GHRP 2 and 6 caveats, just because to give a little bit more better idea about the regulatory landscape. I know that sometimes practitioners would hate to lose products and have in terms of not being able to continue a patient on therapy. And so just to give an update on the GHRP6, the FDA has put them on what they call the Category 3 list, which says that they prefer compounders not to compound them. And so for those of anyone who's still using a GHRP2 and 6, I would imagine that it's going to become less available, and it might be something to consider.
my understanding of it is that really Ipamorelin is just as inappropriate as an option because it helps decrease somatostatins. Is that correct?
Yeah, absolutely. And the other thing I should note is that in even more aggressive treatment protocols, people will tend to go multiple times a day, just because the Ipamorelin is, at least what we've seen clinically, a little bit less effective than some of those GHRPs. So to make that up, sometimes people multi-day dosing. Sometimes, in the morning on fast cardio and then again at night. But by far and away, I'd say most of our practitioners still do the nightly dosing, just like you mentioned.
Yeah. And I have used sublingual in patients who don't want to inject, and it seems to help. Still, it's hard to say. I don't have a poll of people where I can compare injectable to sublingual, but it is an option for patients who are just needle phobia or they just don't want to do it.
And on that note, I should also note that most of the GHRPs, like the Ipamorelin, also have better sublingual bio than something like the TJC or the Smorelin.
Mm-hmm.
Perfect.
Okay.
Great. Well, I don't see any questions, but thank you so much, Dr. Garcia, for doing this with me. What we'll do is we'll save this and send it out as a video along with the PowerPoint slides, and then hopefully we can address it if we have any more questions. I can always be reached at rs@tailormadecompounding.com, or you can go to our website, Tailor Made Compounding. I would be happy to answer any more of the pharmacological questions that you might have, and I'm sure Dr. Garcia is available on your all chat as well. And so with that, is there anything else you have, Dr. Garcia?
I see a question here. It says, have you noticed increased weight loss with BID dosing with CJC Ipamorelin? And do I would say that the times that I've prescribed the CJC Ipamorelin BID in bodybuilders where they're looking for improving strength and body fat loss, fat loss. And I would say it's helped a little bit. I wouldn't say there's been a dramatic change. I definitely see the biggest change with just adding the GHRP. But again, I don't have too many people to pull from. I haven't taken the CJC Ipamorelin regular dosing and split it up. That really isn't something that I've done a whole lot of. Where you're saying kind of take it, Ryan, you were saying take like half, like a small amount in the morning and a small amount in the evening, but still use one vial per month. Is that correct?
Yeah, correct. I think a lot of practitioners tend to do the 100 micrograms of each product. Again, just sort of going more to that pituitary saturation dose and trying to get multiple peaks. But I think just like your experience, I think most of them fairly well optimized people who are just looking for a little bit more benefit. And for most people that BID or TID dosing doesn't seem to have a huge difference, but for some select people, it can push them a little bit over that plateau.
Yeah. Okay. And there's another question here. Do I check IGF-1 levels before and after starting? Well, now the IGF-1 level is part of, it's part of my standard IC blood. So it's always going to be there before. As far as after, no, I do not check it regularly. I'll probably check an IGF-1 when blood work's appropriate. Again, it depends patient to patient. I don't have a set protocol on following IGF-1 because my understanding of it is that it's very random throughout the day and it really won't reflect the outcome of how well the GHRP is working or not working. But you tell me, Ryan, are there any studies that show that it really does, or that there's a certain time of the day that you should check? And definitely back when I've done growth hormone, but I just don't see it really correlate that well with using the GHRPs, IGF-1.
Yeah, so sorry to be a little early on interjecting there, but I would say that the CJC, Pamorelin, and the Ipamorelin, as well as the GHRP6 and 2, don't have a really reliable set range, whereas in the clinical literature, and oftentimes because while we're dosing them together in the clinical setting, they're not usually studied as a combination. However, the MK677 and the tesamorelin are very reliable, I would say, and predictable in their IGF-1 change, which the MK677 is said to give around a 50% increase in IGF-1, and the tesamorelin, that 2 milligram dose is 181 points, and then essentially, 14% less for that 1 milligram dose, which still seems to be quite the increase. But the CJC Ipamorelin and Pamorelin Ipamorelin, it seems to be very, very unpredictable and usually mild increases at best.
Yeah. Again, I'm usually dosing and using it more clinically. Patients usually will note a difference one way or the other. So yeah, I haven't really routinely followed. Next question: how long do you keep patients on treatment? Several months, on or off, or continuous? Well, I don't timeline where patients have to go off of it. Although when I took the peptide modules, Dr. Seeds recommended changing the GHRPs here, occasionally, just so that patients kind of build up a tolerance to them. But my usual dosing is the 5 days on, 2 days off. But no, I don't typically tell them that they have to go off for a certain period of time. Continuous, but not every day. I do the 5 days on, 2 days off.
Sure, and I think a lot of the reasoning behind that alternating protocol, or even some of the breaks in the past, has been all about that downregulation as it occurs on a growth hormone secretagogue receptor 1A. And so with conservative doses of the GHRPs, and you really don't have to worry about that, and it can be done in a relatively fashion. But that is sort of the underlying, I should say, theory behind the reason that people would take breaks, or why in the past dosing high doses of GHRP2 or 6 might go 3 months and then try and take a break.
Okay. Okay, that's all the questions I see.
Awesome. Well, thank you again, Dr. Garcia. I appreciate you joining me today, and hopefully we will do another update as the science and medicine progresses.
Thank you.
Yeah, so much. Thanks, everybody.
Thanks. Bye.